Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by ATTAC Consulting. And it is titled Value-Based Care is a Team Sport, How Providers Can Operationalize Risk Adjustment Initiatives. And I'm very excited to hear from our speakers today, who you'll get to meet momentarily. There's a lot of really cool, I got a sneak preview of some of the material going to be discussed today, and so I think you're really going to enjoy it. A few items of note, some housekeeping items as we get started here. First of all, this is a traditional webinar format, so everyone's joined in listen-only mode, so you don't need to worry about muting your mic or your camera or anything like that. So you just kind of sit back and listen. However, we do want you to participate by asking some questions if you have any throughout the presentation. There is a module that has a little question box, which is different than the chat. There's also a chat thing, but if you have a question, drop your question in the little question box at any time. You don't have to wait till the Q&A. We are going to have time for Q&A at the end, but you can ask it at any time. If we have a big audience today, so if for some reason we don't get to your question, don't worry. Someone will reach out afterwards through email to make sure we get it answered. So even if we're wrapping up at the last few seconds and you got a burning question, go ahead and ask it and someone will get back to you. And then finally, the session today is being recorded. And so what's going to happen is about an hour, maybe two after the presentation concludes, you will receive an email that will have a link to where you can watch, rewatch, share the recording, the webinar from today. And there will also be a link to where you can download the slides. So it'll all be there for you. So without further ado, I'm going to hand it over now to John Gottwald, and he's the SVP of Sales and Client Services, and he will introduce our speakers for today. Welcome, John.
All right, thanks, Garrett. Thanks, everybody, for joining us this afternoon. And before I get to the speakers, just a little bit about ATTAC Consulting Group. We were founded in 2003, as you can see on the screen. So last year we celebrated our 20th anniversary and got the gold star for 20 years of existence. And as you can see, we span across payer and provider across many lines of business. And of our specialty items, you'll see on the right, risk adjustment and value-based care and contracting. So that's a little bit about ATTAC Consulting Group. And our two speakers today are Rich Dalton and Mary Stanfield. And a couple things about them real quick. Rich is an expert in encounter submissions and risk adjustment. He's previously managed encounter submission and risk adjustment analytics teams across various lines of business, including MA, ACA, and Medicaid. And he's also designed, analyzed, deployed, and refined prospective and retrospective programs. And in a nutshell, he's our data and analytics guru. Mary Stanfield, she has over more than 30 years of experience working with provider organizations on health information management and systems. She's worked with physicians and integrated delivery systems to implement pop health and risk adjustment initiatives. And she's basically our rev cycle management and reimbursement expert. All right, real quick, looking at the agenda, you guys can see the screen, so I'm obviously not going to read all this because there is a lot of words here, but we're basically going to look at some different perspectives and goals and areas of alignment, including upstream and downstream. We're going to look at some unique challenges with members and data, and then we're going to talk about some strategies and skills which are required for those data-driven priorities, a little bit about KPIs, and then we're going to talk about some more strategies around distribution of data and actions for pre-encounter, point of care, and post-encounter. And we're going to dive a lot into that last one there. Okay, so to make sure everybody is tuned in and listening, we're going to launch our first polling question. You should see your screen. Which best describes your organization? And you can see there's 5 choices. Pretty simple. ACO, downstream entity, managed care entity, vendor, or consultant.
I'm going to chime in here too and remind everyone these are anonymous, so you don't need to worry about this being shared. So this is just kind of for you to see where you stack among your colleagues, and we'll show you the results here soon.
Yeah, thanks for that, Garrett. Yeah, the names have been changed to protect the innocent, right? Something like that. Okay, looks like we're about 3/4 have voted. I'll keep it open a little bit longer. All right, I'm going to end the poll and then you're going to see the results. Okay. Looks like we got mostly ACOs on this call. All righty. Well, thanks for voting, everybody. And again, welcome. I'm going to now turn it over to Rich Dalton.
Thanks, John. So jumping right in here, we're looking at the slide here for upstream and downstream. And based on the polling, obviously, I think a lot of you are going to know who you are, at least on the upstream side. But what we're calling upstream, risk-bearing contractors, obviously we're calling, ACO or MSSP. And downstream would actually be the providers performing the care in the offices for the beneficiaries. And, these two groups need to work effectively together to achieve the cost savings distributions while providing, a high level of care management for the beneficiaries. And, thinking about the upstream, or ACOs, they're really focused on kind of the macro items of, data gathering, strategy, whether it's for care management or risk adjustment, performing analytics, establishing provider education plans, and along with potentially hiring staffing that would be used to actually perform the analytics and do the data gathering work. And one of the challenges when we're looking at this is the variety of data sources that are available that can come into an ACO. And for that, we could be talking about attributed population demographics. We'd be talking about the EHR, EMR, structured and non-structured data from there. We could be talking about claims data, either historical and current. There's, essentially clinical referrals, maybe even in the EHR data. In certain areas, you could even have, HIEs or health information exchanges available as an input. Even potentially even insights from billing data, for specific patients or populations. And then, of course, there'd be access to, like CMS, the Virtual Research Data Center, where the chronic conditions warehouse is. And then even, non-ACO, providers would also have potentially have data as well if the beneficiaries of the ACO saw a non-ACO provider. That data is something else that could come in as well. So the real challenge there then, when you think about all these different data sources, is then how do you consolidate that data into a cohesive data mart that could then provide the backbone of what would then drive strategy and then ultimately achieve the goals. And that really takes developing the right mix of staff and vendors. And each ACO is going to have to figure out what that mix is. If they're able to develop the work in-house, maybe there's more internal staff, or if they don't want to go that way, they could go more vendors. So it really is going to come down to the ACO to figure out what mix works right for them. And then obviously from there, with the data work occurring in there, there'd then be the analytics to be performed on that data, which would then drive strategy for either care management along with risk adjustment. And that would, that risk adjustment strategy could be, focused on prospective or retrospective, and to really be working on, identifying persistent conditions, the conditions that the member has had in the past, or, even identifying suspect chronic conditions that, the member has never been diagnosed with, but based upon the data, procedure codes, medications, the member history, even the provider specialties that they're seeing, along with maybe even diagnostics that would come in, those could all be used to identify the potential for a suspect condition. And, so you tie that in along with then having to develop, provider education plans. And provider education would then, the point of the provider education would be to ensure that coding is performed completely and accurately, to ensure that as much that the data is accurate that is submitted to CMS, that's going to drive the risk score. And then obviously there could be the need to obviously perform chart retrievals and coding if there ends up being a need to perform, concurrent or retrospective chart review. And kind of flipping to the right side of the screen, looking at downstream care providers, these are the providers actually performing the care in the office. And, they're kind of in charge of, putting the tactics in place for the strategy that the upstream ACO has defined. And that includes obviously scheduling the beneficiaries to be in the office, have to get those members or beneficiaries into the office. And then once they're there, properly documenting the chronic conditions, whether they're existing conditions that have to document every year, or if they're potentially new chronic conditions that maybe the member hasn't had before. And then ultimately performing, care management, maybe one of those chronic conditions requires, a follow-up visit with a specialist. So ensuring that care management occurs, and then developing, treatment plans, which proper treatment plans and, that are documented are very valuable when you're getting to an audit perspective. So it's valuable to have those treatment plans. And then ultimately, kind of was mentioned from, the provider education planning is really this, entering complete coding into the claims that are submitted to CMS for payment. And that could even include, capturing all prescribed medications. So as I noted earlier, there's the potential that beneficiaries could see non-ACO providers, which, the ACO may not have that information quickly and may be delayed to receive it from CMS, but, it would still be important on those visits to capture, all the prescribed medications and ensuring that, labs are scheduled and tests, obviously, for quality metrics. And then ultimately, if there is, if the ACO is requesting chart retrieval or coding, that the downstream provider is able to provide those charts back to the ACO for, so that way the coding and the retrieval, or the retrieval and the coding can actually take place. You can go ahead, John. So I'm just going to take a couple of minutes here just to talk about some of the differences between what we think of in terms of like Medicare Advantage plans and what an ACO would have to deal with. And they are definitely different. And just kind of starting off with and this is an exhaustive list, but just to pick a few of these that definitely are different. So one is, of course, just the way the data is even submitted to CMS. CMS created the encounter submission platforms, RAPS and EDPS for the Medicare Advantage plans. There isn't a submission platform that was created for the ACOs. The data submitted through the Medicare administrative contractors or the MACs or MACs, just like it is for other fee-for-service providers. And then the timing is quite different as well, where December 31st of a given year on the MA side, you get to December 31st for that calendar year, those MA plans have essentially 13 months in non-COVID years and 13 months to have that data submitted, where for the ACO, those claims can be opened by the MAC or by the MAC, but that has to occur within 12 months of the final adjudication date of those claims. So if the claim is only adjudicated one time in January of a given year, you only have, basically a year to add any diagnosis codes you may potentially be able to add to that claim and submit to CMS. So it definitely shortens the window of time that exists. And then just, kind of thinking about some of the ways that Medicare Advantage plans and ACOs can, incent or engage their members. On the MA side, you're looking at, MA plans are able to offer supplemental services such as, vision and dental and silver sneakers and even offering, financial payments for completing a wellness visit. On the ACO side, you're looking at, an ACO can have a beneficiary incentive program or a BIP, where they could potentially offer, $20 for, say, completing primary care services. And there could be, a beneficiary could receive multiples of those if the primary care services are appropriate. But one of the challenges is the ACO can't actually advertise that they can offer that BIP. it's information that's passed to the beneficiary when they're attributed to the ACO, but it's not like they can advertise that, where MA plans can advertise that they have vision and dental benefits available on their Part C plans. And then when we think about what's available in terms of potential lift, when it comes actually down to doing the risk adjustment programs, on the MA side there's really no limit. So you could so a health plan on the MA side could achieve 3, 4, 5% lift potentially from their risk adjustment program if it's aggressive and really focused and has a strong level of if it's utilizing AI powered natural language processing, machine learning, and all these new technologies that are available, that they can really push the top end that could be available for those MA plans, where for the ACOs it's limited, based on what the benchmarks are. There's for each particular ACO, you're looking at a max 3% positive lift. So no matter how strong or efficient or successful of a risk adjustment program that an ACO plan has, or ACO has, you're looking at a max amount of lift. Yet there's no limit to the negative lift, just like on the Medicare Advantage plan. So it's there are definitely some definite limitations that exist on the ACO side. One of the other challenges too is that all the activity for the members is available to the health plan. So in certain cases, a member of a health plan for an MA plan may go visit a non-network provider, but that claim still comes into the health plan for payment. Where on the ACO side, those non-ACO providers, those claims would eventually be submitted back to the ACO from CMS, but it could be a significant delay of up to 6 months. So it definitely would have some impact there on the data available and being fully knowledgeable about the data for each member for either an ACO or an MA plan. Hey, John. So just kind of delve into a little bit, just pick a couple of examples here, just to delve into a couple of kind of data challenges. And so we picked on snowbirds and aged in late in the year. So snowbirds would be, someone who lives in part of the country for most of the year, but say they go travel somewhere else for the summer. So between say June and September or whatever summer months you want to pick, they move away, and they, these, on the ACO, world here, these members can go to any provider that offers, Medicare, fee for service. They can go to any of those providers. And so that makes a challenge, of course, where there could be, like I mentioned before, there could be claims data that the ACO would not be aware of. So, how do you deal with this, and how do you identify these members? And, one of the options, this is kind of delayed, this will be a little bit of a delayed issue, but can you identify them from the claims when they finally come in from CMS? This might be looking towards the future. So if the claims data supports that, hey, this member who lives in, make it up Florida, and goes to New York for June to September, if they have New York claims from June to September, then that could be feed into the analytics engine that could then identify a flag for those members to say, hey, we need to engage those members earlier in the year while they're still, in Florida. Let's come up with a program or some analytics to schedule, earlier appointments in the year to get those members in and be able to document their existing conditions and identify and code that information. Maybe some members will self-reveal as well. If they come to the office and they're asking for how can they, have their meds filled in another state, that information could be passed along again to the analytics. And if there's sufficient time available before that member leaves, perhaps the analytics could even review the documentation that exists for the member. And, there could be the possibility of being able to say, there's still some open conditions. Let's get that member in for another visit, or maybe send them on to a specialist to ensure that they have their, have those visits before they leave for travel. And then when the members finally come back at the, towards the end of the year, and they come back in October or sometime like that, this is always a challenge, is if you get to, late summer, early fall, and there's, a beneficiary with undocumented conditions, it's really going to be important to engage those members with some sort of prospective, outreach or some type of intervention that could be used to document any open conditions that are undocumented chronic conditions. When you go to the age and later in the year, we're looking at members that, and we just kind of picked here, some members that turn 65 after July 31st. And, there's this window of time around the birth date that when the beneficiary can sign up. And, so if you're looking at, the ACOs, they need to obviously be actively welcoming these members, but obviously, like we talked about earlier, they can't advertise their incentive programs, but those new members that are attributed to them, definitely need to be, actively engaging those members, making them aware of their benefits, making them, and ensuring them that there's, a focus on their care management and how that is actually performed, and obviously letting them know if there is an incentive program. I need to take a drink, 1 second. So if they were, and obviously potentially there could be a situation where these members who's age in, they perhaps were, if they were having visits with, say, a large IPA with, that has an ACO associated with it, perhaps there were some visits already that the member was having with some of the other IPA providers. So maybe there is access to some of the medical records. So that would be important to bring those into the ACO if there's access. And then ultimately, if they're if it's a totally new member coming into the ACO, then it would be important to obviously anybody really new to engage them, as I said before, and be able to really capture that medical history. Okay, John. I know this kind of speaks, I kind of touched on this a couple of times here, but some of the challenges that may exist related to sharing of data. And obviously, ACOs are based around, hospital systems, and these can be quite large organizations, multiple hospitals and many practices within them. And obviously there could be multiple EHRs within those, and they may not always talk to each other effectively, but where you could have an EHR within the ACO, and then maybe some other sponsoring providers, developing some type of system, whether it's an API or some sort of partnership, to be able to develop a process for, being able to absorb that data from one EHR into another, so that way there's complete information about the member, or more complete information about the member on their visits. And then if there are, non-sponsoring providers, either, within the IPA or even outside, as we talked about, is there a way to develop a partnership potentially with those providers to be able to come up with a way to have that data brought in? And definitely a challenge, but it's definitely something that could be developed. And I think this now gets turned over to Mary.
Thank you, Rich. So with that, essentially Rich is saying that the upstream and the downstream entities have different challenges, right? They have different things that they do. But what we're suggesting is, despite that, they are ultimately aligned in their overarching value-based care objectives. So if you look at this and think about it at a high level, the upstream, entities are using population data, whereas the providers are using individual EHR data, which ultimately rolls up to and makes up that population data. The upstream, really, those of you in the ACO, for example, are ensuring that the RAF scores are accurate and optimal. And of course, the providers are ensuring that the documentation and the coding is accurate, which correlates to those RAF scores. Upstream is focused on the shared savings, the dollars, the return, and compliance and quality. And the providers are just trying to balance their schedules and time, which really translates to cost. Those providers' time, of course, translates to cost. And each derives satisfaction perhaps slightly differently, but ultimately both are aligned on this concept of quality. So our point here is that there's a lot of commonality and they need to be on the same team. It's a team sport. We suggest that they both have unique contributions to bring to the team and areas where they need to collaborate and work together. So let's look at some examples. Next slide, John. Next slide, please, John. There you go. Thank you. So value-based care is a team sport. And to work together as a team, you need to leverage each other's capabilities. There are things that providers need the upstream ACO to do, to analyze data, provide benchmarks, and there are things the upstream ACO needs those providers in practice to do. Only the provider can treat the patients, can document quality care. And I'm glad there are at least a few provider organizations represented, the provider side, those in practice represented here on the webinar. However, they need to collaborate and work as a team on some of the other strategies that are equally important. Look at the list in the column on the right. For these collaborative strategies, these two entities need to determine who should do what. And really, there's no one size fits all. It depends on the internal capabilities, the size of the group, the size of the ACO, the number of members, and who has line of sight to what, who has the knowledge, the information, the skills. The key is to collaborate to ensure shared priorities are addressed efficiently without any overlap and waste of resources for either the upstream or downstream entity. So for the rest of our time together, we want to discuss a couple of key areas in this respect. And we're going to focus on data and data-driven priorities, and then also the provider processes like the chart reviews and coding validation. Next slide. Thank you, Jen. So first, we'll discuss data strategies and data-driven priorities. Value-based care is absolutely data-driven. You have to have sophisticated data to drive efficient actions by either or both parties in collaboration. Without data, you can't focus your efforts on the right priorities. For example, making sure you're using resources for the patients who need care the most. This graph here is really just a picture to illustrate that as the level of data sophistication increases, your ability to take informed actions and provide the best possible care also increases. And we listed just a couple key activities there to help with this, illustrate this concept. So this is just illustrative, these 3 points on this continuum, but certainly not exhaustive. And the idea I want you to take away is that you need to start somewhere, solve what you can, and just keep making positive progress. So for example, you should collaborate, both the upstream and downstream entities, to pull together all data so you have the complete information on ACO members, which, as Rich was describing, can be difficult to do when you have multiple different EHRs within across your ACO. It's also important to have bi-directional flow of data between the upstream and the downstream parties, which requires, again, as Rich mentioned, it requires a cohesive data mart, a backbone, a data infrastructure in place, and shared understanding of data governance, for example. So, of course, to be data-driven, you need skilled staff with technical skills to manage, support, and manipulate data. So that might be IT professionals and data analysts, whether full-time, part-time, or contracted, or, again, depending on the configuration of your ACO and size and scope. As John described, ATTAC provides strategic consulting, and we've helped guide upstream entities to clearly define their initial data strategies and then refine and expand those when they were ready to keep moving along the continuum. And in doing that work, we find the strategy is different for different ACOs. It's impacted by the EHRs and even by the ACO members themselves. Perhaps their geography can impact the strategy. If you're in a community, for example, where everyone is on a different instance of Epic, you might find all the information you need in Epic. But if you've got some practitioners on Cerner or some of the groups in your ACO on a different EHR, then you might need to tap into a national care network or a health information exchange in order to get the information you need on your ACO members. The point is to identify all sources and coordinate and organize who will pull that together and how it's going to be used. So with that context, John, will you do a polling question for us on data sources?
Yeah, thanks, Mary. And apologize for the slide moving slowly. My mouse wasn't cutting it, so I've moved to the page down and page up button. So, all right. So
Okay.
without further ado, we are going to go to our second polling question. And number 2, are you confident that you incorporated all data sources in your VBC strategies? And please select one. I'm going to launch the poll. Again, are you confident that you have incorporated all data sources in your VBC strategies?
This is really interesting as I'm watching the votes kind of accumulate here. Wouldn't you say, Rich? I mean, it is pretty hard to do. So I'm not surprised to see kind of a preponderance of folks saying they have a little more work to do, because it can be hard to get all that information on a member, particularly if they're seen outside of your ACO, outside of your network.
Yeah, absolutely, Mary. And we're about halfway. Looks like half of you have voted, so I'll leave it open for a little bit longer.
So, any advice, Rich, for those that aren't sure where they are, who they should talk to? Maybe they need to get more collaborative kind of conversations going on about who has what data.
Yeah, I think ultimately it kind of gets back to what I was talking about before. Is about getting the right people or vendors in your organization, and that's really, you're either going to need, if you're going to do it within your organization, or even if you're going to use a vendor, you're still going to need knowledgeable leaders in your organization that understand the data and understand the challenges of being able to pull that data together. And then you're going to need analysts of some level of skill to be able to do that work. But I think you're really looking at having people with advanced degrees potentially, and obviously a history of working in that space, not only with claims data and other sources that come in, but also being able to piece that data together at say a beneficiary level, and then having knowledge in the say the risk adjustment space to understand how risk adjustment is definitely different version of being able to understand just how healthcare data works, because you're looking at kind of performing different analytics that maybe are outside of the norm. Usually it's the risk adjustment folks generally are doing work that doesn't always make the most sense to everyone else, simply because you're looking at identifying gaps that maybe aren't even there or don't exist yet, but they're in the data. They're latent conditions in the data that perhaps just haven't been identified yet, but they're there. And you really need the right skill sets and the right vendors to be able to do that work.
Yeah.
And
well, it's super exciting
work
to
with
see.
imperfect data.
Oh, sorry, Rich.
Sorry,
I was just going to say it's super exciting to see, at this point at least, we have 5 people who've said, yep, they've got all the data. That's awesome.
Yeah, okay. All right, so looks like the majority have more work to do. All right, and these results will be included once we send out the deck. And I did see a question in the question box about this being available online. Yes, Garrett will send that out at the conclusion of the webinar. All right, Rich.
So obviously, once you get this information together, you then have all these different KPIs that you can have available, along with obviously your RAF score. But you obviously want to be tracking your RAF scores or your risk adjustment factor scores, year over year. And here it says by provider, but it really could be by provider, by region, by by any sort of way you want to slice your data up. You can actually measure and evaluate how your scores and trends are working, and really it's about establishing those benchmarks and then being able to track over time and being able to evaluate a program year over year, identify areas of success and identify where challenges still exist, and then being able to take those successes where they do exist, and figure out, okay, how do we apply those to the areas where we're having challenges? And so, an example could simply be regional. Some areas, you could be doing well on one side of the city and not so well on the other side of the city. And it just depends. Maybe there's a river or there's whatever, and there's just issues that there's geographic issues that can cause problems, and then you have to figure out a way to solve those issues. So it really can be challenging to figure out, like, why are your RAF scores good in one area and not another? Obviously, capture of your HCCs year over year and identifying those and being able to track those over time, and really building not only a way to analyze it, but a way to visualize it. And I think it's very important to have proper data visualization tools that not only either the vendor can provide or the ACO staff can produce, but they're very valuable to share up to ACO leadership to be able to track how the success is going, and where perhaps, are there certain HCCs where capture or recapture is underperforming, and is there a reason why that might be able to establish some sort of prospective outreach to try and drive that recapture up, and that should definitely be being worked throughout the year. Obviously, annual wellness visit rates would be important to track and make sure that are they occurring properly, are they happening, and making sure you don't want to be getting to September and still having a significant portion of your population without having a wellness visit, because then it's going to be hard to get those in later in the months. And obviously there could be quality metrics, and then obviously trends in the patient population and other items sure that you can see. But let me toss it back to Mary. So, but I think you get the point here. You need to have KPIs to measure and evaluate and track your success on how you're performing. So I think we go back to Mary here.
Thanks, Rich. Yeah, that's a good list. The KPIs are important. So now we want to kind of shift gears. We said we were going to talk about two different key things, one being the data challenges, KPIs, which we chatted about that a bit. Now let's spend some time on strategies downstream in the provider practice. And I'm hoping if you're an ACO that you're hearing maybe some nuances that will help you work well with your providers in practice, and so that you'll glean some insights there. This chart really just, it shows you, first of all, it shows you the data analytics and EHR information as input into these processes that we're going to talk about before, during, and after the patient visit. One thing I want to emphasize here is there are 3 points, the pre-encounter, point of care, and post-encounter, where we're going to distribute and act on data. But we've set this up, and really, pre-encounter, point of care, post-encounter, those are for a patient. They're sequential, right? They're sort of linear, but we've intentionally listed this as a cycle because the feedback loop from post-encounter observations is super important. You want to make sure that what you're learning in this process for patients over and over is fed back upstream to ultimately improve knowledge for all of the staff that are involved at any of these 3 process points, so that you ultimately result in correct RAF scores, right? So let's talk about some of the nuances and the lessons we've learned for each of these 3 points where we are distributing and acting on data. So John, if you'll switch slides, the first one is the pre-encounter provider process. And this is chart prep, really, before a scheduled encounter for an ACO member. We've seen this done by nurses, nurse practitioners, medical assistants, HCC coders, really quite a variety. And there's multiple different ways to make this work well. It's rarely possible to review 100% of ACO members who have an appointment. In fact, we don't even recommend that. Don't advise that at all. This is where data is really key. I said that these processes have to be data driven. You should use data to identify which patients are likely to have gaps that warrant investigation and looking, for example, for persistent conditions that haven't been reported. In reviewing the chart, of course, you're identifying these conditions. And at this point, for some of you, they have multiple sources of data and all of the information they need about a patient. Some of you are still working on making sure they have that. And we're seeing more and more tools used to enable this process, usually presented in the problem list, and they're starting to use our artificial intelligence. There are also bolt-on or standalone tools that can help make this chart review process more efficient, more targeted. And we've worked with clients to help define and refine their edits to decide what algorithms to turn on or to turn off to select priority cases for chart review. And I will say the tools that are available to do this are improving, but false positives can really be a problem, particularly with AI tools at the outset. So it's wise to have a human in the loop. You're going to hear this talked about. It's the latest buzzword, the HITL. And so you can work out the kinks of the algorithms and the tools you're using. I do see a variety of approaches. Happy to chat about some examples of this if folks are interested. But I want to make sure we touch on all three key steps in the process. So in effect, this process is a way to get the providers up to speed and the staff in general up to speed on what's most important and most critical to document as you start this process, pass that on to point of care here now, and then close the loop as we're describing. So at this point, we're distributing and acting on data during the patient encounter. And this is, result of the chart prep. We've identified gaps at that point, and we're passing that on to the provider so it can be addressed during the patient's visit. And the key is to do this in an effective way within the provider's workflow. I think this is within the EHR specifically. So you don't add more burden to the providers who we know are already overburdened. And I think this is a difficult point for folks, in fact. And a couple of just lessons learned and tips I would give you. You need to make sure you know your provider's workflow, how they document, how they're using and interacting with the EHR. I was talking with a CMIO of a large medical group last week, and he said about 50% of the primary care docs do a chart prep before they're seeing their patients because it just makes their day in the clinic so much easier. Do you know, if you're an ACO, have you talked with the downstream, those practices? Have you talked with them? Do you know what your providers are doing? How many of them, to what extent they're doing a chart prep themselves? Can you leverage that process? Which providers are using scribes, and how could the scribes potentially help? I've seen these point of care processes work really well. I've also seen it have little to no impact, or worst case, just really tick off the providers because it's giving them one more thing to think about. I had a client so the reason I say that at point is that you have to do this well, and you have to do it in partnership with the practices with those providers and leveraging the staff that's around them. I had one client who contacted me because they had several people doing pre-encounter chart reviews, and they were using Epic in-basket messaging to relay the gaps that they found. And the problem was very few of the providers ever looked at the in-basket messaging. Those messages were just never open. So we don't recommend using any sort of messaging outside of the EHR. We're seeing a lot of best practice alerts are the current go-to. And the only problem with that is, and it's super simple, right? Pops up, it's right embedded within, just in time. It feels like a great strategy. It probably is. The only problem with that is everyone now is seeing that and is doing that for multiple different things. I was shadowing a provider who demonstrated her process in Epic and how she would associate diagnoses with her visit notes with an order. She was a gerontologist who was super savvy in maneuvering and completing her patient documentation on the same day of the visit. But she also showed me a queue of about 8 patients from the prior day, and each that she still hadn't gotten to and hadn't been able to finish up. Each of those patients had like a dozen BPA alerts, every one of which required her to take some action. So you don't want to overuse that either. There are unintended consequences of using some of these tools. And what I would tell you just in terms of what we've learned is we've spent time shadowing providers at the elbow in the clinic, and we always end up with great insights to help in this process. So for instance, the diagnosis pick lists themselves, those drop downs in Epic only allow for 30 items in the list. So what's in their list? Maybe you need to fix the pick list. What truly is your provider's documentation workflow? And There are multiple ways, for example, in Epic to associate a diagnosis with a visit or an order. Do you know how those providers and the practices typically do it? What can we do to make it as easy as possible for them to document? Otherwise, you'll get either inactivity or, worst case, really tick them off. So I'd say where we're seeing that work well is strong physician leadership, and we've spent, time in the clinic and we know what's going on. Post-encounter, I'm not going to spend as much time here. This is pre-bill, where we are doing a double check or validating the coding is correct, the coding and documentation match. Again, you cannot look at 100%. We use algorithms here, and I can give you examples of what algorithms that, how we do that. Essentially, we're looking for erroneous code patterns, high risk codes, etc. And we've done a lot of work with our clients, helping them to recognize and refine what algorithms they turn on, what they turn off. You don't want to delay the claim submission, so you have to clear the queue every day if you create this kind of a queue. And when you first turn on the edits, you can have an explosion of cases dumping into a queue. So you don't want that to happen. You need to dive in and really make sure that your edits are intentional and you're only pulling out the key things that you want to target. So with that, looking at the time, we're at about 10. John, do you want to do a polling question?
I think we're going to skip that in the interest of time, and let's just go to slide 20.
Okay. All right. Great. Thank you. So we said we were going to talk about those two key sort of big things, the data and then the processes in the provider practices. We ran through those pretty quick. This slide really is just to make sure that we haven't oversimplified things, right? There are a lot of other conditions, a lot of other things that you can do as well. And as I've alluded to, kind of where you start depends on multiple factors, including your tools, your people, what internal talent you have, how many, who your ACO members are, how many you've got. We're not going to address all these additional factors. I just want to comment on a couple points and give Rich a chance to comment on anything here before we go to and open it up for you to ask us questions. Tell us what you want to know most about. So I'll touch on the first one. We've talked about a lot of strategies that require resources, and that itself can be a challenge, right? So I'm sure you're thinking, well, how do we do all of this on top of everything else? And what I would say is it's really important to use your resources wisely. Remember, take some action, make some progress. Don't try to boil the ocean. So you want to prioritize and allocate resources. So to do that, again, data is key. Determine your financial objectives. What's your shared savings goals? And then define a budget associated with that, considering how you're going to distribute those dollars to be successful for a positive net value. And then keep monitoring that, pivot, adjust. If you're not making progress, don't keep doing it. So a lot of monitoring, a lot of data, and then change plans. Rich, what would you like to comment on here?
I think I would just toss in something really, really short on attribution, which obviously is probably one of the more challenging things to really grasp about the ACOs and how this works. But I think one of the things I just point out is, if you're an ACO working on prospective attribution, you tend to end up with more decedents or more folks that pass away in that data, along with, or in that population, along with, a higher, per beneficiary per year expenditures among the seriously ill folks. So it's kind of one of those attributes that you're going to get if you have a prospective attribution. If it's retrospective, it's kind of the opposite. Not that it's tremendously lower, but it is definitely lower, where you're not going to have as many of the decedents, so you're going to have a slightly lower expenditure. The prospective, you're not going to know the members that you're being assigned really that well. Retrospective, you are going to know those members. And then ultimately, now that there's voluntary selection, where if a beneficiary is on the site, on the Medicare site, and is signing up, and they select a PCP that's within an ACO, they will be assigned to that ACO. So they're, in essence, those beneficiaries are selecting themselves into which ACO they would want. So I think it's really interesting how the attribution assignment can really be impactful to the types of numbers that you end up with and what the acuity level could be of your population.
Yeah. Well, and I'm
All
going to
right.
take the risk. I know we wanted to leave 10 minutes for questions, but I really want to make a 30-second comment on the mutual incentives, because I think we often think about these mutual incentives as monetary. And it sometimes feels like the upstream and the downstream aren't working together. And we've been trying to emphasize in this time today that they actually have commonality. They have a lot of points of shared objectives. So what I would challenge you with, especially for those ACOs on the line, if don't automatically assume incentives means dollars, right? I think we often do that, a shared bonus or somehow sharing the savings or giving a bonus for certain activities. But I want to encourage you to think outside the box. If providers, for example, I'll just give you one example. If providers' top priority is time with their patients or seeing that their patients' health improves, that's what they're really all about. That's what gets them up every morning and makes them feel good at the end of the day. So how do you incorporate that into your value-based care approaches? Maybe patients with high RAF scores or a certain number of HCCs receive more care coordination. So when the doctor sees that patient with diabetes, their patient's already met with the diabetic educator. And those kinds of efforts and giving maybe even just super complex patients, you schedule those, they have high RAF scores, you schedule those patients with the providers with a little more time. So really want you to think about how you can better align care delivery with the value-focused care outcomes that everyone wants to achieve. So with that, yes, let's open it up to questions. Do you, John, are you going to MC that for us? What are we hearing
Yeah.
from the audience?
Yep. Thanks, Mary. Thanks, Rich. So just this will be in the deck. So just a little blurb on how ATTAC can help. And so we got many questions. We'll get to as many as we can. And then, like Garrett said, there'll be follow up with the questions we can't get to. So this first one is for Mary. And the question is, you talked about strategies before, during, and after a patient visit, but we just don't have the staff to do all three. Would we benefit from starting with one or two? And what should we do first?
Oh, that is a really good question. Yeah, because I've been saying prioritize. And I guess I would say yes, do something. any one or two of the three is better than doing nothing. And really, which one you prioritize will depend on your particular context, what staff expertise you have, where you think your greatest risk might be. And we can help you perform a risk assessment to figure this out and make sure you're using your resources as effectively as possible.
Okay, thanks, Mary. The next one is for Rich. And the question is, our ACO has some beneficiaries that leave the state for several months each year. Are we better off engaging members before they leave or when they return?
You're generally always better off engaging those members earlier in the year. It can just be very challenging to get those members in once you get to fall and holidays start coming up. So what you really need is you need to develop, like a prioritized targeted program that would engage a population that would focus, even maybe down to the HCC specifically to say, okay, who do we want to get in first for each for at least groups of HCCs or even individual HCCs, say who do we want to get in by the end of Q1 or the end of or somewhere in Q2 before the member leaves, and that would be really important to accomplish. And I think, like maybe we covered earlier in the deck on the snowbirds piece is if you're able to identify those members at all through the data that with the CMS claims that'll come in down the road, being able to identify those members would be really important to do, and then develop flags around them so you can absolutely make sure you're prioritizing those members ahead of even our beneficiaries, ahead of other beneficiaries in the ACO, to make sure you're capturing those HCCs.
Okay, great. Thanks, Rich. This next one is for Mary, and Mary, it's a little long one, so bear with me here. It says, I work at a clinic in our ACO. The other primary care clinic closest to us has staff that identify which patients need an annual wellness visit and following up to get them scheduled. However, at our clinic, we just work from the list that the ACO provides us. Is that a problem?
Oh, yeah. Well, no, honestly, that's not necessarily a problem. as long as the efforts aren't overlapping, aren't being duplicated. So the key is, as I was talking about that collaboration, the key is to make sure that all attributed patients have an annual wellness visit. All attributed ACO members have an annual wellness visit. And the clinic staff and the ACO should collaborate to confirm that that's being done once, right? Someone's doing that and they're doing it well with the best information. So in the circumstance you described, you want to confirm the ACO is sending you a list of that. If you're relying on the ACO, you want to confirm that the ACO is sending you a list of the annual wellness visits that are needed for all of your attributed patients, not just, for example, the snowbirds or the ones that have aged in, as Rich was describing. And the other clinic you mentioned, who is doing this on themselves, they want to make sure that they're confident they have all the attributed patients likewise, right? So are they aware of the patients aging in? Are they getting it all together? And so you get the idea here. The point is to not have any wasted duplication of efforts, and you're working together, and you know the information you're working off of is good. And it's not unusual in an ACO for some clinics, depending on their staffing and the way they're set up, for some to do A and B and others not. The ACO, it really just depends on making sure. And the goal is to do it, to get it done, right? Work together, get it done, and do it as efficiently as possible.
Yeah, absolutely. Okay, thanks, Mary. Okay, this next one is for Rich. I'm assuming it would be for you. Rich, how would our ACO be able to determine if we can build our own risk adjustment program or if we need to hire a vendor?
So I guess that would really come down to, I guess, if the ACO can assess the current state of a risk adjustment program that they may have. Is this a mature program, or is it not? Is it a program that is being that isn't mature yet, that is still being developed or even considered? So I think that's going to have a definite impact, and I think that's also going to impact, how quickly. And this may be silly, but how quickly does the risk adjustment program need to start producing results? And obviously, it'll probably be immediately, but obviously, it could come down to, like, what does that time schedule look like? And because it could definitely be quicker to go to a vendor, but then obviously with a vendor you're subject to their modeling, their analytics, their tool sets, so you're definitely giving up something when you do that. And granted, some vendors have great modeling and great analytics, but you're going to be limited to what they're doing. Where if you're an ACO that really wants more control, then it's a longer timeline. But then you would need to hire the proper staff, like we talked about earlier, with the advanced degrees and the analytics and those skill sets, then be able to develop, a program that could then, produce the results that the ACO wants to prioritize versus what maybe a vendor prioritizes. So I think it comes down to, where that program is and how fast the results need to start occurring is really going to drive a lot of that answer.
Okay, thanks, Rich. And we're out of time for questions, but we certainly will follow up with the ones we could not get to. And I'll hand it over to Garrett.
All right. Well, hey, thank you all so much. This was a fantastic presentation. I know we did get some questions in about will the slides be shared and all. Yes, you're going to receive an email afterwards, and give us another hour or so, and you will receive an email that have a link to the recording, to the slides, to all of that. Real quick, as we close out, wanted to encourage you all to head over to vbcexhibithall.com and check out the ATTAC Consulting virtual exhibit booth that they have over there. This is also, there'll be a link directly in the slides. This is like a hot link that'll take you there. A lot of cool resources there. You can read up on them, see what they're doing, just get familiar with them. And if you'd like to reach out, of course, there's a bunch of different ways to do that. And then finally, if you would like to reach out to our speakers today or to the ATTAC team, feel free to do that. So John, if you can go to the final slide. There we go. Or you just reach out to John directly and he'll connect you to whoever you need to be connected with. Or feel free to reach out to me. I'm happy to facilitate an introduction for you or answer any questions that you have. So thank you all so much for joining us today. Thank you all for our speakers, and thank you, John. Appreciate you guys joining us today. Have a wonderful rest of your afternoon.